and good afternoon. Happens to be the last lecture of the meeting, so I am honored and humbled. So today I'm going to talk about something that I'm exploring in the context of the Diabetes Technology Clinic at University of Virginia, non-insulin therapies for type 1 diabetes. So again, as far as disclosures, I don't have any financial relationships and no off-label usage. So the outline of my talk includes the review of the available evidence for the use of these various agents in addition to insulin as adjuvant therapies for type 1 diabetes. So a fundamental fact we should never forget that insulin and insulin alone remains the cornerstone for management of type 1 diabetes, because type 1 diabetes by definition is insulin dependent. And therefore, other therapeutic options remain as adjuvant strategies in addition to insulin for type 1 diabetes. This is of course, a fundamental fact. So first, I'm going to talk about the SGLT2 inhibitors that have lately come up to the fore, both for type 2 diabetes and also for type 1 diabetes. I would like to mention the EASE trials, which is empagliflozin as adjunctive to insulin therapy in type 1 diabetes, published in Diabetes Care about a couple of years ago. The purpose of this phase 3 trial was to evaluate the safety and efficacy of 10 milligram versus 25 milligram of EMPA in T1D patients already on intensive insulin therapy. They studied a total of about 1,700 patients with type 1 diabetes in two separate trials, one over 26 weeks and one over a year. And the primary endpoint was change in hemoglobin A1C, with secondary endpoints being time in range, weight, blood pressure, insulin dose, and hypoglycemia. So the main results of this was that both in the EASE-2 and EASE-3 trials, the mean hemoglobin A1C reductions compared to placebo was about 0.5% with 10 milligram and about the same for 25 milligram dose of empagliflozin. The weight reduction was also similar. Both these doses causes about a 3 kilo reduction in weight, so that's approximately about 8 pounds. And as you all know, SGLT2 inhibitors do so because they make people lose about 60 to 70 grams of glucose in the urine within a 24-hour period. That's a lot of calories. That's about 300 calories or more getting out in the urine, and therefore most of these people tend to lose weight. It lowered the total daily dose of insulin by about 12 to 13%, so there was a reduction in the insulin needs. It increased glucose time in range, and this was most important, especially in the postprandial phase, where the glucose time in range was improved. So it increased glucose time in range by about 3 hours in a day. So that's a significant improvement in overall glucose control with the addition of these SGLT2 inhibitors to intensive insulin therapy. And of course, as it has been shown in patients with type 2 diabetes, it lowered systolic blood pressure by about 3 to 4 millimeter mercury with the addition of these agents. So again, this showed all the benefits as has been shown in people with type 2 diabetes. Now, the adverse effects, and these are significant because there was in these patients about a 2 to 3-fold increase in the risk of or the incidence of diabetic ketoacidosis. In the placebo group, the rate was about 1.2%, while in the treatment groups, it varied between 3 to 4%. Severe hypoglycemia was rare in both the treatment groups. However, because of glycosuria, as one can expect, there was increased risk of genital infections, mainly balanitis, vulvitis, and perineal inflammation in the drug treatment groups, about a 2 to 3-fold increase compared to placebo. However, deep organ involvement, that is urinary tract infections, was not different between groups. Symptomatic hypotension was a bit more prevalent in people on drugs, but they were not statistically significant because the numbers were small. What about some of the other studies There was Tandem studies where they tested sotagliflozin. Now, sotagliflozin, as you know, is a combined SGLT2 and SGLT1 inhibitor. And they tested 2 different doses of sotagliflozin. The Tandem trial tested dapagliflozin. The DEPIC trial tested dapagliflozin versus placebo. The results were essentially similar to the EASE trials, that they lowered hemoglobin A1C, lowered weight, lowered total daily dose of insulin, and lowered rates of hypoglycemia. However, as in the EASE studies, there was increased risk of diabetic ketoacidosis and genital infections. So, because there was an increased risk of diabetic ketoacidosis, we need to explore this and learn more about the type of diabetic ketoacidosis that we see in these patients. As has been described in patients with type 2 diabetes, there's a higher prevalence of euglycemic ketoacidosis. That means these patients, their blood sugar levels are not 300 to 400 milligrams per deciliter. More often than not, even with ketoacidosis, the blood sugars are usually less than 250 milligrams per deciliter, sometimes even less than 150 milligrams per deciliter. So we have to be alert towards the development of ketoacidosis. So in the clinical trials that have been shown, and especially in the EASE studies, the diabetic ketoacidosis was more severe with the higher dose than with the lower dose of the SGLT2 inhibitors. And when you look at all the different, throughout the drug class, that is empagliflozin, dapagliflozin, and sotagliflozin, the diabetic ketoacidosis risks were similar across all of these drugs. And these risks were shown to be higher in those with uncontrolled type 1 diabetes. So therefore, the recommendations are that if you want to use these drugs, you should first try and control the diabetes better with insulin, get their hemoglobin A1C below 9%, and then consider adding these medications. The risks were also higher in those on low carbohydrate diets and those who are taking alcohol excess, because of course the risk of ketogenesis are higher anyway in these groups, regardless of whether you want to use these medications or not. So what are the possible mechanisms of diabetic ketoacidosis in patients with type 1 diabetes treated with these drugs? Now, as you know, and as has been reported, the glucagon levels are higher in these patients treated with SGLT2 inhibitors. And why is that so? We are not entirely sure. There is some reports that the alpha cells in the pancreas contain SGLT2 receptors, and hence inhibiting them increase glucagon secretion. But we do not know the exact mechanism of this. And hyperglucagonemia promotes ketogenesis. There's also has been shown that there's reduced ketone body clearance by the kidneys when you start these patients on these medications. There's also a risk for volume depletion that can increase the risk of ketoacidosis. And of course, glycosuria. When there's glycosuria and the blood sugar falls, and you get this so-called euglycemic ketoacidosis, the patient themselves reduce the dose of insulin because the blood sugars are not that high. And therefore, lowering insulin dosages can increase the risk of ketogenesis in these individuals. So how do you manage these patients on SGLT2 inhibitor? Is it the same management as the standard management of diabetic ketoacidosis? The short answer is probably no. Satish Garg from Colorado suggested this so-called STITCH protocol that he has used in his patients with SGLT2 inhibitor-induced ketoacidosis in type 1 diabetes. The first part is to stop the drug, obviously, but the important thing for you to remember is that these drugs usually have a long half-life, so even if you stop the drugs, the glycosuric effect might last for 3 to 4 days, so you have to be careful. You inject a bolus dose of insulin, which is 1.5 times the usual correction dose of insulin. You give carbohydrates, about 30 grams. You hydrate the patient with fluids, and you recheck ketones every 3 to 4 hours. You also should have a high index of suspicion for ketosis, and you should have the patient monitor for ketones at least once or twice a day, irrespective of their blood glucose levels. And if the ketones levels go over 1.5, you need to be alerted, and the patients need to be checked more frequently. There's also another study that came out last year from Bernie Zinman in Canada that suggested a stop DKA protocol for these patients. It's essentially similar to the STITCH protocol: stop the drug, test ketones and glucose, oral fluids and carbohydrates, and they have a definite algorithm for insulin dosing based on glucose values. Again, have a very high index of suspicion for ketosis, ketones more than 1.5 to be alerted and recheck in a few hours. Next, we change gear to GLP-1 based therapies as adjuvant therapies for type 1 diabetes in addition to insulin. So both GLP-1 receptor agonists and DPP-4 inhibitors have been evaluated singly and in combination in the so-called adjunct trials and other small studies. Results are comparable between all of these studies: a modest lowering of hemoglobin A1C, an insulin dose reduction of between 5 to 50%, depending on the study. And again, the main effect on insulin dose reduction, like the SGLT2 inhibitors, is on the bolus dosing, not so much the basal. Weight reduction of about 2 to 5%. Most favorable results were in those who were C-peptide positive. Of course, there were higher rates of hypoglycemia and GI side effects, especially with the GLP-1 receptor agonists, because they slow down gastric motility. Hence, the suggestion is that GLP-1 based therapy may be more suited for those with recent onset type 1 diabetes who are overweight and the patients who are engaged, who are at low risk for ketosis and hypoglycemia. Have I used GLP-1 receptor agonist in patients with type 1 diabetes? Yes, I have, very sparingly, especially in those who are grossly overweight with class 2 or class 3 obesity with BMI of more than 35. And we are seeing more and more of these patients in our clinics, even with type 1 diabetes. They have severe insulin resistance, and in those we also use other insulin sensitizers, namely Metformin. Pramlintide. Now, pramlintide has been around for a long time. As you know, pramlintide is an amylin analog, and amylin is secreted by the beta cells in the same rate as insulin. And when beta cells are lost, amylin is also lost. And as you know, amylin works by slowing gastric emptying and reducing glucagon levels. So pramlintide has been tried between the dosage of 15 and 60 micrograms 3 times a day in over 800 patients with type 1 diabetes in several randomized controlled trials. Hemoglobin A1C lowering is modest, weight reduction is modest, and insulin total dose reduction is also modest. The significant limitations for pramlintide, as we all know, includes nausea, vomiting, tachyphylaxis, and of course cost, and 3 times a day injections. No patients want to give 3 times a day injections in addition to giving insulin injections. Efficacy, however, is currently being tested as continuous infusions with insulin in closed-loop controlled clinical trials. Small studies are currently happening in the US and Canada to look at the co-infusion of insulin and pramlintide with the insulin pump in patients with type 1 diabetes. Next, we want to look briefly at metformin. Metformin has been used in type 1 diabetes, and we continue to use it off-label. It has been tested formally in the removal study, where they tested the use of metformin over 3 years. Results showed a minimal change in hemoglobin A1C, a minimum weight reduction, no change in total daily dose of insulin, and adverse effects were mainly GI discomfort. However, an important point of metformin was that it lowered the average maximum carotid intermedial thickness, suggesting that it may have beneficial long-term effects on progression of atherosclerosis. And again, we are seeing more and more cardiovascular disease in patients with type 1 diabetes because they're living longer with better treatments. So metformin may be an option in the long term. So to summarize the effects of these various adjuvant therapies on hemoglobin A1C, weight, total daily dose of insulin, hypoglycemia, and ketosis, I've tried to summarize in this slide. SGLT2 inhibitors have beneficial effects in A1C, weight, total daily dose of insulin, but has been shown to increase the rates of ketosis. Having said that, have recently started a study where I've started to use SGLT2 inhibitors along with closed-loop control insulin therapy in a clinical trial that is currently funded by the NIH. Hopefully, we should finish the study in the next few months, and I'll be able to come back and report the results at a subsequent meeting. GLP-1 agonists have similar effects as SGLT2, and there's some suggestion that it does increase the risk of ketosis, but the jury is still out. Pramlintide, the effects are modest in all of these, and metformin, as we have shown, has minimal effects on some of these parameters while improving possible markers of atherosclerosis. Finally, some concluding thoughts. High proportions of type 1 diabetes patients not achieving glycemic targets, coupled with rising trends of obesity and metabolic syndrome in patients with type 1 diabetes due to increased longevity, may increase the need for adjuvant therapies in addition to insulin. The positive CV outcome trials and renal outcome trials with SGLT2 inhibitors and GLP-1 based therapies in type 2 diabetes could be extended to those with type 1 diabetes. However, long-term outcome studies in type 1 diabetes are needed with these adjuvants before we can use them routinely in clinical practice. So with that, I thank you. My granddaughter Mira thanks you for listening for these last 3 days to her grandma and grandpa. Thank you.